So everyone, today we've got another fabulous case study for you. This patient has hip pain. Can you work out the diagnosis for this patient? We're going to guide you through the assessment, how we came up with the diagnosis, and the key things you need to know for your patients in the future. If you're ready, let's dive in. Hey everyone, Khalid here. Welcome back to Clinical Physio. Let's take a look at today's hip patient. So, we have a 21-year-old rugby player and they are complaining of pain at their left hip, particularly around the groin area. They've been playing rugby for a long time and they've noticed this has gradually been getting worse over the course of the last 4 to 5 months. They report that it came on gradually. There was no particular trauma, there wasn't a particular tackle or a particular game that they noticed that it was suddenly worse. It's just been getting a little bit more irritable over time. So what about their key symptoms? They've noticed that they have a clicking or clunking sensation at the hip. This doesn't happen all the time, but sometimes they notice when they're turning quite sharply, they can feel this clunk sensation at their hip. They also notice that it's worse when they're changing direction. You can imagine this happening a lot during a rugby game. And they also notice that it's worse when they're doing a deep squat kind of maneuver in the gym. Naturally, they're trying to keep strong for their rugby, and when they do a deep squat, they can feel this pain around their left hip in the groin area. So this individual is a very fit and healthy 21-year-old, no major past medical history, not taking any medication for anything, and they haven't really had any change in their activities that might suggest as to why this has come on. It's just been getting a little bit more irritable over the last 4 to 5 months, and they're looking for our help. So what did we go through with our patient on the objective assessment? Well, first of all, we observed the hip, we had our patient walking up and down to look at their gait, and there were no major abnormalities here. There certainly wasn't any particular bruising or swelling around the hip. They had really good muscle tone in all areas, as you would expect from a strong rugby player. And when we look at their gait, there was no abnormal pattern. They were actually walking really smoothly, and it wasn't actually painful for them to walk up and down in our clinic. Then we looked at their active range of movement of their left hip. And again, we didn't find a huge amount of abnormalities. First of all, they had full range of movement in all the main directions of flexion, extension, abduction and adduction, internal rotation and external rotation. However, there were two main movements that seemed to irritate their hip at the end of range, and that was passive hip flexion done in a supine position and also prone internal rotation. So you lie the patient prone on their front on the bed, and then we internally rotate the hip from there, and that also seemed to irritate their symptoms. Finally, we had one particular special test that we did, which was a Physio test, flexion, adduction, internal rotation, and this was positive for the patient. Now, there's loads of clues from the subjective and objective here that I can see that might lead me to a particular diagnosis. I'd love you to take the chance to do the same, have a look at the subjective and objective clues, and let us know what do you think is going on for this particular patient. Okay everyone, time's up. Let's take you through our diagnosis. So this particular patient had a diagnosis of femoroacetabular impingement. So FAI is what we call a motion-related disorder at the hip, i.e. the symptoms come on when someone does particular movements. And for this individual, we noticed the deep squatting and the twisting movements which seem to aggravate their symptoms. What FAI is a condition where we have bony overgrowth, either on the acetabulum, as you can see here, which is what is called a pincer lesion, or additional bony growth on the head and neck of femur, which is called a cam lesion. You can also have a mixed picture where patients have both. So what this means is that there is early symptomatic contact between the femur and the acetabulum, because the additional bony growth means that there's additional contact when the two surfaces move against each other. And that's why it is so clearly a motion-related disorder, because it's when these movements occur that you get that early symptomatic contact and the patient's pain comes on. So with that in mind, what are some of the key signs from the patient's subjective and objective assessments that gave us this diagnosis? So first, let's look at some of the subjective signs. First of all, groin pain. 83% of patients who have FAI report anterior groin pain as the area in which they have their symptoms, and this was certainly the case for the patient. Now, FAI is a condition that can cause clicking, clunking, or a catching sensation for patients. Now, it's really important for me to say that not every patient with FAI will have this, but if you do have a patient that does have these symptoms, it will naturally increase your suspicion that it could be something like FAI or certainly another joint-based condition, because it's normally the movement of the joint surfaces from one to the other that causes that catching sensation. And this is certainly something our patient had when they were doing their rugby. Also, the classic aggravating factors associated with FAI. We talked about this being a motion-related disorder. And when we think about positions of deep flexion, and if we think about rotation, these are going to be movements that move those joint surfaces against each other, the femur against the acetabulum, which can be, therefore, the movements that aggravate their symptoms because they will bring on that early symptomatic contact because of those bony overgrowths between the femur and the acetabulum. Next, the timing of onset. This patient said that they did not have a sudden trauma that brought on their symptoms, but instead it came on gradually over a 4 to 5 month period. And we find this is consistent with FAI because 65% of FAI patients report a gradual, unexplained onset of their symptoms. Often it can just be the fact that they've been doing more sports than usual, or they've been doing high intensity, or it could just be that they've been doing it for many years and these symptoms have been in the background, but then have recently got aggravated and worsened over time. And finally, the general demographic of this individual. We find that FAI is more classically seen in the younger age group. This is a young 21-year-old rugby player who's very athletic, and we find that it's the younger, more athletic groups who tend to have this condition because these are the individuals who are doing deep flexion positions, who are doing twisting movements, who are doing high intensity exercise and workloads that put pressure on the femur and the acetabulum. So this is also quite consistent from a subjective history perspective for our patient to have FAI. And then we have our objective assessment findings. What were the things in our physical examination that guided us in the direction of FAI? Well, we have this fabulous paper where the reference here is at the bottom from Ishoy et al. From 2021, where they noted 3 key tests that can really help them in the diagnosis of FAI. So the first 2 tests are tests that we can use to rule FAI out. So, if a patient has no pain during the Fadir test and no restricted range of movement during the Faber test compared to the unaffected side, that can help us rule out FAI. Now, just for a second, let's clarify that. We're talking about when patients have no symptoms on those tests, and that's because these tests have high sensitivity levels, meaning that we expect these tests to be positive in these patients. We expect patients to have pain during a Fadir test, as our patient did. And we expect patients to have some kind of restriction to their range of movement or pain during range of movement of a Faber test compared to the other side. So when patients have no symptoms from those tests, it helps us to rule out FAI. But as we said, our patient did have pain during the Fadir test, which makes it less likely to rule out. But there is also a particular test that Ishoy et al. Utilized that's really good for ruling in FAI, which is the prone internal rotation test. So as you can see, we've got a clinician doing this on the screen where we're moving the hip passively into internal rotation with our patient lying prone. This test has a 94% specificity for FAI, meaning that if this test is positive, there's a 94% likelihood that we can rule it in. And this is what our patient had on their testing. So those subjective history markers combined with those physical tests together is what has given us our patient diagnosis of FAI. So a lot of you have been asking with these case studies, okay, that's great, but how do you treat the patient? So I thought I'd give you a quick summary of some of the key principles that we use for FAI. There are two main ones that come to mind. The first is load management, and you see us talking about this a lot. What we mean by load management is adjusting the patient's sporting and activity levels. If it is the rugby that seems to be particularly aggravating this patient's symptoms, reducing the amount of rugby or reducing the amount of twisting and turning that they're doing is likely to have a positive impact on their symptoms. Now, this doesn't have to be forever. It might just be during this particular period of time where their symptoms are really irritable to try and help them overcome that really painful stage of their FAI. Now, the second principle is exercises. And this will vary for every single patient because different patients will have different movement disorders. You'll find, as we said, that this is a motion-related disorder, and some patients will say it's the twisting. Some people will say it's the deep flexion with the squatting. And so we have to try and look at the patient's movements and work out which one is the one that's most painful, and that's the one I have to target with my exercises. So, for this particular patient who's explaining that it's the rotation and the squatting that seems to influence them the most. Well, therefore, with the rotation, I need to work out exercises that I can give this patient which work on strengthening the internal and external rotators of the hip, but crucially, the movements are comfortable for my patient. I don't want these exercises to bring on the patient's pain because that's simply going to aggravate things further. So can I think about certain rotational exercises that are comfortable for this patient? Then we think about the squatting. Naturally, the squatting is what's irritating their symptoms. So again, we have to work out a way in which this patient can squat that is comfortable for them. Now, a possible idea here is something like a box squat, where the patient will be squatting to a specific height where the box is and then pushing back up again. And the idea there is that because the box is at a certain height, you can tell them that the height that is comfortable for them, and that's their limit. So they can squat down to the box, get before the limit of when their pain comes on, and then push back up to hopefully make it easier. So it really is about identifying and tailoring the specific movements and exercises for your particular patient, which is the key to FAI rehab. So everyone, I really hope you've enjoyed this video. If you have, please support us by smashing that like button and subscribe to our channel for all our best updates. Remember, we've got loads and loads of resources on our Instagram account @clinicalphysio and on our membership website member.clinicalphysio.com. We've got brilliant webinars for you, including FAI itself from the Hip Physio Mimic Gem. We've got hip differential diagnosis and loads more that's really going to help you with your hip and MSK rehab. My name's Khalid. Thank you so much for watching. See you soon here on Clinical Physio.